So in the next 20 minutes, I'd like to defend the negative trial. Here are my disclosures. They have not affected what I'm going to say. So recently, there have been quite a lot of negative trials, and some people feel very negative about them. Before I make my defense, I'd like to remind us of all of our reasons for doing research. I put it to you that the majority of us who do research ultimately do this because we want to improve the health of our patients and society, and ultimately our own health once we're in hospital ourselves. And when we get involved in research, it usually starts with either somebody making us aware of a problem, or we ourselves identify a problem. We may come across something which is very intriguing, which prompts us to explore something, and then we develop a hypothesis. We may go further and develop a research study, and if we're lucky, we get some funding and complete our study. And every study will have some conclusions. They may be positive or negative, but we discover something new, and if we're lucky, these results get talked about, and if we're very lucky, they get included in guidelines and protocol and implemented, and ultimately, hopefully, the patient or the society or healthcare systems benefit. And I believe that negative trials have an important role in this journey. Now, to start off, at the moment, we define negative or positive trials simply by a p-value. So if the p-value is less than 0.05, we say this was a positive trial. And if it's more, it's higher, then it's a negative trial. But actually, the p-value is simply an indicator of the likelihood of this being a random event, an event by chance. And I put it to you that p-values should be viewed as a continuum. There's statistically very little difference between a p-value of 0.049 and 0.05. But for us as researchers, it's a huge difference. It makes a huge difference to have a positive or a negative trial. And I think that needs to be changed. But most importantly, I think trials need to be interpreted and viewed in their totality, looking at the primary outcome, but also secondary outcomes and, importantly, safety outcomes. And it was really prompted by this article here, which is worthwhile reading, published recently in the New England Journal of Medicine. And the authors prompt us to look at negative trials a little bit more positively. And they urge us to make some inquiries and ask certain questions. For instance, even if the primary outcome wasn't met, is there an indication that a particular therapy or intervention may still have a potential benefit? And I think that's a very important question. If you just look at the adrenal study primarily was a negative trial. In this adrenal study, patients were randomized to hydrocortisone versus placebo. And there was no difference in 90-day mortality. However, patients who received hydrocortisone spent less time on the ventilator and received less blood transfusions. And I put it to you, this is a very important outcome, something we like to see, we strive for, and certainly something, if I was a patient in the intensive care unit, I would like to have. I would like to spend as little time as possible on a ventilator, and I would want to have as little blood transfusions as I could get away with. So a negative trial can still have some positive, show some positive effects. If a negative trial shows non-inferiority of one therapy or one intervention, I put it to you, it's still very important. And to make my point, I chose the ARISE study. And the previous speakers already alluded to this and talked about it in much more depth than I will. But as you've heard, it was a negative trial. It showed that patients who received early goal-directed therapy did not have a reduced mortality. And as already been elegantly pointed out, despite the fact that it was a negative or a non-inferior trial, I still think this study showed us very important things. It showed us that, firstly, our intervention, our clinical practice had improved significantly since the original RIVERS trial. And it also informed us that we didn't need to spend extra money and extra processes, put extra processes in place to implement more complex, sophisticated early goal-directed therapy programs, because current treatment, current standard of care was already sufficient. There's no doubt we can improve further, but at this point, there's no point and no indication to invest more money. And I think that's important. Another trial was the previous renal trial, which was a randomized controlled trial looking at 2 doses of renal replacement therapy. And it was prompted by a single-center study which had suggested that more dialysis or more renal replacement therapy was better for patients. Now, this large randomized controlled trial showed that patients who'd received an intensified dose of renal replacement therapy did not have a better outcome compared to those at a standard dose. And I put it to you, the fact that the higher dose or the lower dose was not inferior is important, because it means that we don't need to use higher doses, we don't need to waste money unnecessarily, and we don't have to ask our nurses to increase their workload by supplying and delivering higher doses of renal replacement therapy. I also believe that negative trials may show us may identify groups who still benefit from the therapy we were investigating. Although the benefit may not be seen in the total group, there are certain subgroups which may benefit. And as an example, I'd like to highlight the SAFE trial. The SAFE trial was a randomized controlled trial comparing saline with albumin in patients in the intensive care unit. It was a negative trial because at 28 days there was no difference in mortality. However, in a predefined subgroup analysis, it turned out that patients with severe sepsis randomized to albumin had a benefit. As shown here, in a multivariable analysis, controlling for baseline factors and clinical factors, patients who had severe sepsis at time of enrollment had a clear, significant survival benefit at 28 days. So the benefit may not be clear in the total group. Individual subgroups may benefit. And in this case, it was predefined before the study started. When evaluating a negative trial, it's obviously important to look at the methods and to see whether the study was followed as per protocol. Even if the study was conducted according to protocol and has the appropriate number of patients per group, it is still possible that the treatment delivered to patients wasn't quite appropriate or wasn't quite as expected. And as an example, I'd just like to show the SPLIT trial. The SPLIT trial was a randomized controlled trial where patients in the intensive care unit were randomized to fluid resuscitation with either saline or a balanced solution. And the hypothesis was that patients in the saline group may get more acute kidney injury, based on previous studies suggesting that saline was nephrotoxic. As you know, this was a negative trial. There was no difference in the incidence of acute kidney injury between the two groups. Now, you may say that saline, therefore, is not nephrotoxic. At the time, this was the largest randomized controlled trial conducted in this area. Previous smaller studies had suggested that saline was potentially harmful to kidney function. But when you look at this very well conducted randomized controlled trial in more detail, it turned out that patients in the saline group had received far lower volumes of saline than in previous studies. And actually, in order to see a nephrotoxic effect from saline, previous studies had suggested that patients needed to receive at least 3 liters in 72 hours. And the effect was predominantly seen in those who had received large volumes of saline. It turned out that patients randomized to this study were receiving little volumes with a median of only 2 liters in 48 hours. And only a very small number of patients had received large volume fluid resuscitation with saline. So maybe there was never an effect to be seen, given the fact that fluid resuscitation had changed over years and the volumes of fluid had reduced. So before we conclude that saline indeed isn't nephrotoxic based on this trial, it's important to remember that the patients receive relatively small amounts of saline. And although it was a negative trial, it did show, it teaches much more about saline, made us go back to the original physiology, and also assured us that small amounts of saline are less harmful than we may have thought based on previous studies. And then finally, these negative trials may also give us some safety signals. And again, to highlight this, I'd like to go back to the SAFE trial, which not only looked at patients with severe sepsis, but also patients with traumatic brain injury. And as you know, the subgroup of patients with traumatic brain injury had a significant survival or mortality increase at 28 and at 2 years. Patients in the saline group had a survival benefit. So we had the overall trial was negative, with subgroups, patients with severe sepsis having a benefit from albumin versus patients with traumatic brain injury and increased mortality at 28 days and 2 years. So I hope I've shown that negative trials can have some positive effects and can give us positive messages which we can take back to our patients, because they may identify patient groups who particularly benefit from an intervention. They may identify those groups in whom the intervention should be avoided because they come to harm. And they may actually identify therapies or interventions that are neither beneficial nor harmful, but completely unnecessary. It follows that this has financial implications, and clearly if we can avoid those interventions that are either costly or harmful, we will avoid wasting money and we will serve the healthcare system and society in general. And then finally, negative trials often teach us a lot. They may be negative, the primary outcome may not have been met, but we learn through this and we generate new hypotheses which help us designing our next studies and advancing medicine, as we've just seen in the development from rivers to 3 large randomized controlled trials, as it was highly well documented in the previous talk. And although I wouldn't say negative trials are the best way of answering a research question, I believe that negative trials can have positive messages. And I concur with the authors of this blog on the BMJ website, published 2 months ago. And they argue that negative trials are positive because they tell us something, they highlight harmful intervention, they make us avoid things, and they make us save money. And with that, I'd like to conclude. Thank you very much.